Thank you, everybody. Welcome, and we're happy that you could join us today. I'm Susan Gregg. I'm the director of UW Medicine Media Relations, and I've had the pleasure of working with the scientists that you're going to see and hear today in the virtual tour, as well as talking to them after the tour with questions you might have. I also want to thank the Council for Advancement of Science Writing and the National Association of Science Writers for hosting this series. Now let me tell you a little bit about the scientists from UW Medicine that you're going to be seeing and hearing from today. We have Dr. Geoffrey Baird, who's the interim chair of UW Medicine's Department of Lab Medicine and Pathology. We have Dr. Keith Jerome, who heads the Virology Division and directs the Virology Lab. We have Dr. Pavitra Roychaudhuri, who is an acting instructor in lab medicine and pathology at UW Medicine. And then we have Dr. Alex Greninger, who's the assistant director of the UW Medicine Virology Lab. After you see the video tour, there will be an opportunity to ask questions of our scientists. And to do that, you need to use the Q&A. Chat will not be used to post questions, so please use the Q&A. So I think it's time now, Randy, if you can start the video. Thank you.
Okay.
Welcome. My name is Geoff Baird. I'm the interim chair of the Department of Laboratory Medicine and Pathology here at UW Medicine. Welcome to the clinical laboratories. This is one of our clinical laboratories spread out amongst many different sites around Seattle as part of UW Medicine. We have about 150 faculty and about 1,500 staff that are doing millions of tests a year for the Seattle region, UW Medicine, and actually all around the country. And of late, I'm sure you're all aware, starting in March, we've also been doing the majority of all of the COVID testing in the Seattle region and actually for King County and a lot of Washington State. What next I'd like to do is I'd like to introduce Dr. Keith Jerome, who is the division head of virology here and the director of the laboratory, and he's going to show us the laboratory here around us and where we do all the different types of virology testing that are done in the Department of Laboratory Medicine and Pathology.
Hi, I'm Keith Jerome. I'm the head of University of Washington Virology, and it's a pleasure to give you a tour about our virology lab and where we do so much testing. What you're seeing now is the laboratory that we had before COVID that we've expanded tremendously to do so much testing we need to do now. Testing starts here. This is where clinical specimens come in. They get logged into these computers and set into our information system so that we can do the testing. You see we have 3 stations here now. You'll see downstairs we've built about 30 more of these so that we can do enormous amounts of testing going forward for COVID. Now I'm going to show you where we actually pull the nucleic acids out of the virus. Remember, the nucleic acid, RNA, or DNA is the stuff of life that makes up these viruses, and that's what we actually detect. So the first thing you have to do is pull it out from the way the virus packages that up. And we use these instruments. They're actually all robotic. Everything happens automatically. Come on, let's take a look at another one. This one's actually doing some of the testing now, and you can see things moving around. All this can happen and allow our medical laboratory scientists to go off and do other tasks to just get as many tests through as we possibly can so that we can help as many people as we can. Once we have the RNA out of the virus, we bring it into this room. And what we do here is actually amplify it. This is where the PCR, or polymerase chain reaction, happens, where we take a small portion of the virus, and if we can find it, we make that one copy of virus into thousands and then millions. And once we do that, we can actually detect it using instruments like this. And if these curves on these lines actually come up rapidly, we can tell that the virus is there. We can also tell how much virus is there. So this is really where we take all those thousands of specimens we have, find the vast majority which are negative for COVID, and find those few that are positive. When we do find those positives, they go into our sequencing effort so that we can find out exactly what that virus is made of. So I want to take you down and look at that and let you talk to Pavitra Roychaudhuri, who will show you how that really works.
Thanks, Keith. Hi, my name is Pavitra Roychaudhuri, and I lead the genomics and bioinformatics arm of the University of Washington Virology Lab, where we're focused on sequencing SARS-CoV-2 and other pathogens. Once we have a sample that is positive for SARS-CoV-2, the next step is to determine the genetic sequence of the virus in that sample. And that is what we do here in this lab. Over here is our lead scientist, Hong Xie, What she's doing here is preparing sequencing libraries that are obtained from the samples, and those libraries are going to go on one of our 3 sequencing instruments on this side. Once the sequencing instruments have run, they generate a lot of data, and that data has to be analyzed, and I write computer programs to extract the genetic sequence of SARS-CoV-2 from those large data sets. Once we have those sequences, what I try to do is then upload those to public databases so that they can be made available to scientists around the world. And next up, you'll hear from Alex Greninger, who will give you a tour of our dedicated COVID testing facility.
Thanks, Pavitra. So I'm Alex Greninger. I'm the Assistant Director here in the Clinical Virology Lab at the University of Washington Medical Center. Here is our receiving and logging in area for our new floor. It's an entirely new floor of just for COVID. This is our COVID lab. We run about 7,000 samples a day through here now. You saw what it was like upstairs. Now you can see down here from the second floor. So this particular setting, we receive samples in these boxes, unbox them, and then move them into different tiers and buckets. So depending on where the sample's coming from and what kind of turnaround time it needs. And then, so these go into these buckets and then get processed during the day. So over here is where we do our processing, accessioning of samples. So if you come on in here, you can see upstairs we used to have only 3 spots where we would be able to receive samples. Now we have sort of more than 30 across the entire area where we can log in samples. You can see all of them. It's a part of laboratory medicine that people don't talk about. People are very focused on the analytical portion. This is the pre-analytical portion where you have to make sure you have an order for a test, you have the right sample, the right time. You're going to the result's going to mean something, and we have to be able to transmit that result. So that all has to be logged in, make sure everything's correct before it goes to the instruments. So we don't get to control how the samples come in, taking all those samples every day, and we have many different platforms that we run. So we have to move the samples from the tubes they're collected into tubes that can run on the instruments. And so that's what we do here. So if you come in here, you can see we're logging in those samples, and then when we get to this room, we are decanting them actually from one tube into the next, one tube into the next. It's a very manual process, but it's very important to be able to run all the samples. So then the samples have to go on many different instruments. For instance, here we have the Pelagic Panthers, which are actually widely across the United States. There are over 1,000 of these. These run on transcription media amplification. They can run, each one of the instruments can run 1,000 samples in a day. So these are the Alinity M instruments from Abbott. They are very new. We're just starting to get them running here. And they also can do about 800 to 1,000 a day, each one of these instruments. These really have only been authorized for HIV and SARS-CoV-2 testing. So they're very new. They've been out in Europe for several years, but here in the United States, they really just came out from the SARS-CoV-2 pandemic. So this is the Roche Cobas 6800. We have 2 of these instruments. These guys are very high throughput. They do a lot of samples very quickly in a highly batched fashion. So 90 samples at a time will come on over here on this track and be taken to this side where they get moved into different tubes. And then on a different track over here, they get extracted and run the PCR. Same thing as the LDT, just all sample to answer. You just load the samples on the instrument, and then the instrument will give the result out. And then at that point, it's down to the informatics folks, who basically are a huge part of the laboratory to make sure that we can get these samples, these results out to individuals. So from the pre-analytical to the post-analytical, they're involved through everything we do. And that's the University of Washington Virology Lab that we built in the last 6 months. Thanks to Pavitra, Keith, and Jeff for a great tour. And now we got to get back to it. All right, so GCLP week. Got to make the sequencing protocols, finishing the validation on those, and getting all the information.
So I see we have some questions that have come in, and Geoff Baird is going to look through those and parcel out who is the best person on our team to answer those. Thank you,
Sure.
Geoff.
I'll just sort of rotate through the group here because I think we can all answer them. So maybe Keith, for that first one there, now that we've lived through such an intense period, what are the new or different techniques or protocols that we've developed that we're going to be using for the next outbreak? Are we sharing those sorts of things?
Yeah, that's a great question. Thanks for that. And there's, well, I could talk about this for about half an hour, so I won't do this, but we've learned so much. We were fortunate, you know, early on, we made a decision. I distinctly remember Alex and I talking in January and said, we need to get ready for this. And so we started to prepare. And I think that's a lesson that we really tried to share with everybody is if you hear about a pandemic and you have the capability of starting to prepare, you need to do it. And that's why we were ready in frankly, we were ready in February. It took us a little while to get all the approvals to do things, but we were ready to go. So that's important. We've learned about the importance of the sequencing effort that Pavitra talked about. It's so important to be able to know exactly what's making up this virus that you're doing. In fact, if SARS had come here before it came to China, we would have been able to find it, and we actually published a paper on that. Our sequencing program can find a virus that looks like the SARS from 2003, we would have known it was here. So that's really important. And I think the last lesson that I'll talk about that is so important is great communication with the public health community. We're lucky here in the state of Washington to have a really strong state laboratory. We've talked for years about being a surge lab if, God forbid, a viral pandemic would ever come that was just more than any one lab could handle by themselves, that we would help them out. And that all got actually activated, of course, this time. And it's been incredibly gratifying to see how well an academic institution like the University of Washington and the state lab can actually work together. So tremendous lessons. I sure hope this doesn't happen again, but if it does, I think we'll be even more prepared than we were this time.
Thanks, Keith. That was a great answer. There's probably a bunch of more other answers. I just wonder if Alex or Pavitra had any further things that they wanted to add to that, or we can move on. Alex?
Yeah, I think Keith gave a great answer. I think that really this is sort of the process that we go through in testing, right? We have this before, when there's a new organism that comes out, you know, the samples usually go to the CDC, they go to central labs, and then we go to the state public health labs, and then we go to the clinical and reference labs, and then finally we get some point of care tests, and now we're seeing more innovation, rapid antigen tests. And so, you know, I think that, you know, as like South Korea learned a lot from the 2015 MERS COVID outbreak, and they were a little bit more prepared, I think the United States would be much more potentially prepared for anything new virus that comes out. And it's also worth saying that every virus is different. So, I mean, you know, coronaviruses, we haven't had a new pandemic coronavirus here in the United States. And so we had to like go back and look at like what the serologies work for against the nucleocapsid protein versus the spike protein and the dynamics of the immune response there. So, you know, it's sort of history doesn't repeat, but it sort of rhymes. It's sort of like that is what we're learning, we're seeing.
Oh, Pavitra?
Yeah, on the spirit of, on the topic of sharing, I just wanted to mention the CDC Spheres consortium. This is something that came out of this pandemic, but it's this initiative that was established by the CDC that brings labs around the US together. And so that is something that we have used to share a lot of our information and protocols and data with different labs, and hopefully that will put us in a better place for the next pandemic.
Great. The next question is actually, it's probably more the topic of a book than anything else, but Alex is our resident metagenomicist, which is sort of techniques that are involved in looking at all sorts of viruses all at once and applying techniques to look honestly also at the evolution of viruses. So as an evolutionary virologist, maybe Alex, and then also Pavitra and Keith, I'm interested to hear your answer. But Alex, why don't you start off with this? Did the first viruses evolve after the formation of cells, or were they present billions of years ago?
Right. So this is a great question. There's tons of work. It's hard to prove anything here, but nonetheless, I mean, another way to formulate it is, does the chair or division head come first before an assistant professor? And the answer is very clear that it is. You know, you need a host to parasitize at some level. So you have to have, you know, when there was a ribosome that was created, there were RNAs that would parasitize the ribosome, and then viruses are obligate intracellular parasites. And so there has to be a cell for them to parasitize. There's got to be something that they need from the cell. So they really can't necessarily exist in their own, or else they wouldn't be defined as a virus. So they really have to come after a fully fledged virus would have to come after a primitive cell. But they've really attacked every single part of the eukaryotic cell. So even as the eukaryotic cell evolves and evolves new organelles and new pathways, they up their game as well and develop new ways of antagonizing those throughout. So it's a constant Red Queen.
That was a great answer. Anything else there? Oh, this smiles. Yes. Okay. So I think that was a pretty good answer. These are parasites. Next one is maybe for Keith. We could start. There's been a lot of controversy over the Abbott rapid result test And there's a couple of those, just to clarify. There's both the Abbott ID Now, which is a molecular test, and Keith can maybe tell us a little bit what that is. And then there's also an antigen test, which is yet a different technology. And are we doing the same test as those? And are there issues with false positives or negatives with those Abbott tests?
Sure. So I've actually spent a lot of time thinking about this and talking about this, as Jeff well knows. There are the two kinds of these rapid Abbott tests. One is a molecular test. It's pretty similar to the PCR sort of things we talked about. That test is fast, 15 minutes. It's not quite as sensitive as the tests you'd get in a laboratory like ours. So you can get what we would call false negatives. That is, the virus is actually there and that test doesn't see that. There have been some high profile cases of outbreaks that have probably been associated with missed cases. So, there's certainly some utility. Getting a result fast in some settings is very useful. We do have rapid tests. The ones that we offer at the University of Washington, we've vetted very carefully and show that they have sensitivity that's essentially identical to our tests that take full time. There's just not enough capacity to do thousands of those. So you can do 10 or 40 in a day. In the most emergent cases, somebody comes into the emergency room or something like this and needs a test right now before they have maybe surgery on their head and neck. So these sorts of things we can do. A lot of the interest now has been in these antigen tests. These are the little cards. They almost look like a matchbook, sort of, and you just put a swab in there and you wait for a line to show up 15 minutes later. They don't need any of the fancy instruments we showed you. It's 15 minutes. Everything sounds wonderful there. The flip side is those are a lot less sensitive than the tests that we do in the lab. And we talk in the laboratory sometimes about orders of magnitude. Each order of magnitude is tenfold, right? And so those are about 4 or 5 orders of magnitude less sensitive. So literally thousands of times less sensitive. That can be a real problem. We certainly don't want to miss people who have lots of virus, particularly if they're likely to be infectious. Those tests also can give you some false positives. They'll tell you have the virus when you don't. So we're really struggling with how to use those right now. I think there is a school of thought that says that if we can sort of just test a group of people, whether that's everybody, there's not enough tests to do it everybody, but if you found people at really high risk, if you tested them every day or every other day with these tests, even if they're not perfect, you can catch people as their infection is first coming up and maybe keep them from transmitting in those days before they would infect anybody else. That remains to be proven in the real world. And one thing to remember is, of the Abbott antigen test, big headlines, they've made 150 million of these or will have by the end of the year. Well, there's over 300 million Americans, which means we're not all getting that every day. And so how to actually use that when they can't be used in this testing every single day, at least for everybody, is still a matter of discussion. And I think we're really gonna have to wait until we try some things and actually have some carefully performed studies and really understand what works and what doesn't.
Thanks, Keith. And to that point too, just in the news today too, we're aware that there was an outbreak in the West Wing of the White House, and it was disclosed that the president had been negative with the Abbott Binax Now antigen test that Keith was saying. This is the very, very insensitive one. Whereas at the same time, it was disclosed today that he's actually been positive by using testing like we do, but at a very low level and a decreasing level. Right now, I mean, there's obviously the highly publicized discrepancies where one test, and that's actually what we would expect to be the case, because we just know that at the level of virus that's present in someone who's recovering, it's just much less likely that an antigen test could detect that low level, but a PCR test could detect that level. I'll probably take the next one here because it can be sort of a brief answer about asking about the Seattle Coronavirus Assessment Network and significant findings that have come out of SCAN. Just to clarify, so that represents an effort that we help and support periodically, but it is a separately run effort within the University of Washington, UW Medicine. UW Medicine is an incredibly large entity with over $1 billion of research funding a year, and so they are a separate project that we have, of course, supported multiple times. And right now, one of their main efforts, too, is really supporting us. And by us, I mean UW. They are doing a sampling strategy to sort of do testing on a daily basis for samples of UW faculty, staff, and students looking for outbreaks, for example, on Greek row and things like that. And we've helped in that effort too. But I think many of us here get a daily text saying, do you have any symptoms today? And if you do, or for on a random reason, they will actually call us in and do that. And so they are both looking at those results too, also looking at results of multiple different virus tests, respiratory virus tests, tracking flu should it come, other related viruses too. And so it's a research effort and a community surveillance effort. And it is explicitly really not what we're doing, which is in UW Virology, we do multiple research studies too, but the lab that we showed you in is really focused right now on both clinical testing, supporting our community in that way to make those clinical decisions, and then in Pavitra's case too, really helping us out understand the genomic epidemiology of the virus by allowing us to track what are the mutations that happen when, and then what does that mean that this virus that has this mutation, this virus has this mutation, did this one then become this one and transmit this way. So that's what we're doing, and we're I think complementary to the coronavirus assessment network. The next question I actually will just ask, it's a similar question, but I'll just ask Pavitra, does the sequencing allow you to see how the virus is mutating or spreading through people in Washington?
Yeah, absolutely. And that's why we're doing it. We want to keep an eye on mutations that come up and watch how this virus evolves over time. And you expect the virus to mutate over time. That's what viruses do. And what's important is to track this over time. And the best way we can do that is by sequencing our positive samples and depositing it and sharing it.
So Pavitra, with a follow-up question that I've been asked a few times, has the virus mutated in a way that's bad, that's made it worse? Or are there bad mutations and good mutations?
We have to clarify what bad means. So by bad, what you mean is mutations that are associated with a poor clinical outcome, or that maybe are resulting in higher viral loads, or make the virus more transmissible. So those are the things that mutations can impact on the phenotype of the virus. And so we keep an eye on that, as I said, so we watch for mutations that come up, and we can go back and then do studies that say, can we look at the outcomes of all the people who had a virus with this particular mutation versus that one, and compare that to see whether there's any relationship there. And so far, we haven't found anything that's associated with poorer clinical outcome, but we have found some mutations that are associated with higher viral loads. The most famous of these is the D614G mutation in the spike protein that got a lot of attention in the media.
Okay. Any other comments from Alex or Keith on sequencing?
Not particularly. I think Pavitra covered it perfectly. It's really, thankfully the coronavirus is a big viral genome, and so it actually has to mutate kind of slowly. So that's been one thing that's been helpful here. It's not necessarily like the flu, but it is. It does have a lot of real estate it can put mutations down.
So Alex, I'll put you back on the spot again with since you showed us that in the tour of the logging area, seeing how labor intensive that is. Have you tried to roboticize parts of that?
Yeah. So the answer is yes. The big picture is just how atypical and abnormal this is right now. This scenario is. We are doing our annual volume for molecular testing every 5 to 6 days. Right, there's just not many things that grow like that in just a matter of a few months, honestly. Typically, we do about 50,000 PCR tests a year, and now we're doing about between 8,000 and 9,000 a day right now. And so that's just a really difficult. We have automated aspects of it. I mean, one of the problems is we're a reference lab, so we don't get a say in what overlake or what someone else might collect a sample into. And since you have all the different form factors and sizes of tubes and nasal swabs, nasopharyngeal, oropharyngeal swabs, those are different swab types, that makes it really hard to automate those particular processes. For the sites that we have, like the drive-through sites where we've had a little bit more say and we've been able to work with them for a long time, we've actually, one of the things, we bought up 40 times the US supply of a specific tube type so that we could collect into that specific tube type and know that we have a large volume in that tube type. And then that tube type was compatible with our instruments, so we wouldn't have to do any of that decanting step that I showed. So trying to, really wring, when you're running a sample every 10 seconds, really trying to wring out every step possible. And obviously the informatics has done a huge part of that in terms of making sure we get orders. And so we don't have to spend originally, just even a few months ago, we were spending a lot of time entering paper requisitions. So just trying to squeeze seconds out of every sample, honestly, is very important for the whole process.
Any other comments from the group on that? No? Yeah, so the other thing I'll add too is, yes, so we're definitely trying to roboticize where we can. All those problems are super real. And the other thing I'd just like to sort of just tell the group that on top of that is this sort of superstructure of, it's really expensive to do all of this too. And so what you saw, that floor, it had to be bought. All those instruments didn't exist. They all had to be bought. And we've had to hire well over 100 people to do that. We've had turnover, so we're continuing to hire folks too. In the middle of the pandemic, with people moving from other states to even come and get jobs here. And so I'm glad that actually, I think it's Sally who asked that question. I'm glad that resonated with you, and you saw what was a real challenge for us, is that it's very labor intensive. And when you see on the news that, like, where are the tests? Well, the tests aren't just like a little thing that's this big, that we can just buy a bunch of little widgets. The tests are labor and time and space and money, and you can have the instrument and then the instrument can just sit there doing nothing too. And so a lot of pieces need to come into play, and the logistics and IT and everything has just been an enormous headache to deal with. And we've been making it work, but it's been very, very difficult. This one, maybe I'll ask Keith. Why is testing turnaround time so variable within states and or between different healthcare providers 7 months into the pandemic? And then a corollary to that is, how widely used are those all-in-one machines that are assumedly a bit faster?
Yeah, that's a great question and very practical. We've all heard the horror stories of tests that take 2 weeks to get a result back. And our median turnaround time is less than 24 hours and has been for months. Really early on in this whole pandemic, the first thing that occurred to me when it was all here in Washington, and we were one of less than a handful of labs other than the state public health labs could actually do this testing. My first thought was to be able to do as many tests as we possibly could and just get those tests out. It was actually thanks to Dr. Baird, who said, well, there's something else you need to think about. We need to think about what's our turnaround time. And Jeff would say turnaround time equals PPE. That's equals personal protective equipment. That is, we had to get results back to the clinicians taking care of our patients so that they knew, is this COVID, is this something else? Because, it was using enormous amounts of PPE, and how do we balance these things? And of course, there's shortages of everything at the time. And so since that time, we've really tried to balance doing as many tests as we can, but never sacrificing that turnaround time, because it's critically important to get a result back. And so, our goal is always to get something back, within a day of when we receive it. And we've done a good job with that. In emergency cases, we can get things back a lot faster than that. But for just the average person who goes to one of these clinical sites, for the city of Seattle, for example, the specimens come to us, we want to get those results back. So I think it's really important. I think providers as a whole have gotten better. I think we're still ahead of the curve on that in terms of getting things done, and we're proud of that. The all-in-one machines are getting to be more common. Pretty much any competent lab can run those. When I talk about the testing we were starting to prepare in January, that's what we call laboratory developed tests. So it actually uses existing instruments that we have, and a lot of manual steps, and we invented that ourselves. Alex and team and I was involved in, and so we made that, and there are really only a handful of labs in the country that can actually do that from scratch. But these all-in-one tests, a lot of people can do. So there's thousands of them that's around, as Alex pointed out. Companies are making them as fast as they can, and it's hard to get them. I mean, Jeff's worked tirelessly to get us as many of those as we can, because it takes an awful lot of work to do our manual test. And you saw those instruments, you can sort of put the sample on the front and an answer comes out the back. And that's really, really helpful, again, to get samples, to get tests done and to get them done quickly.
Thanks. Yeah, thanks for that. And just to put that into context a little bit for the how hard it is to get some of these instruments, the one that Alex showed at the end of his thing that had the sort of the glowing blue light, that's a Roche instrument called a 6800. That instrument has a big brother instrument called the 8800, which is used in the very, very large commercial reference laboratories like Quest or LabCorp. My understanding from Roche is that they make a handful of those a year on Earth, something like 3 to 5 or something like that. And they now have orders for several hundred of them. You know, companies, even gigantic trillion-dollar global conglomerates, cannot all of a sudden make 100 times more things than they used to. So that's a real limitation on getting those things. But to the question too, just to build a little bit on what Keith said about the turnaround time being so variable, we have actually very closely monitored our turnaround time wanting to do that, but that's just not been a luxury that other folks have had, especially the large commercial testing laboratories. They are the lifeline for many hospitals in this country that rely on these external large commercial reference labs. And when all of the, you know, when there's 100 or 200 or 1,000 hospitals all sending you your testing, all of a sudden, you know, it's great even if you make, where you said our capacity is maybe doing 10,000 tests a day. It's great if you can do 50,000 tests a day, but what if you get 300,000 on that one day? That's just going to take you 6 days. There's nothing you can do about it. And so they are really flooded with volume in all of our larger sort of colleagues that have larger institutions, larger companies and you know, laboratories. And so there really isn't a good solution for that right now. And that's why we're struggling with things like antigen testing and point of care testing, et cetera. I really do feel that the best answer though to the supply and demand issue here of we have, you know, not too much demand and not enough supply of lab tests, I think it has to be a large part of reducing demand. And, you know, supply will get there, but it's going to be a real problem. Speaking of supply, maybe Alex, you can talk a little bit about what's being done in the lab to prepare for this flurry of testing that we're supposedly going to see in November, December. Yeah,
so this is a great question. It's really sort of the million-dollar question right now is sort of what's going to happen with testing vis-a-vis the winter. I mean, you see in the Southern Hemisphere, they had very limited flu seasons. I mean, there is pre-existing immunity to many of the seasonal respiratory viruses that come in the winter, the flu and RSV and other coronaviruses. And if people are wearing masks and are socially distancing, and Washington State's done quite well, honestly, really top 5 state, honestly, overall, it seems like, in terms of its response and cases, then we probably could see a more limited flu season. You never know. And you have to, and our job is prepare to make sure we're the insurance, right? So we got to prepare for a flurry of testing. But it'll be interesting to see. You know, I think the short answer to this question is honestly pooling. You know, we were one of the first, actually probably one of the first labs to get authorization in the country for pooling back in June. And we use,
what pooling is?
Yeah, sorry. Pooling is basically taking 4 samples that come into the lab and putting them together, mixing like, you know, equal parts of each, and then running that tube, that new tube on your analyzers. So it saves reagent. It can also save a little bit of manpower as well. And so, you know, you pool that, and then if they're all negative, if the result's negative, that means they're all negative. And if it's positive, then you got to go back, find those 4 samples and run each of those samples and see which one was positive. And so that's basically how we handled the July surge across the country. I think one of the other angles to the story here about these supply chain issues and the flurry of testing is that the surge doesn't actually have to happen here in Washington State. It can happen in other places. It could happen in the Northeast, in the Mountain West, in the Southeast, and all of a sudden our reagents that we think we're going to get every week are now cut by a certain percentage because they're being reallocated to those states and those areas. And so, you know, we have to be prepared both for a surge in testing here, as well as the fact that maybe our reagents might go away a little bit, not all the way, but a little bit. And so that's where pooling's super helpful because it uses less reagent. It ensures us, it gives us like 4 or 5 times the overall analytical capacity. Now, importantly, it doesn't save you really anything on the pre-analytical side because you still got to log all the samples that you're getting in. And you have to do even more work because you have to like make those new tubes. You have to have a bunch of liquid handlers. We bought like maybe like 7 or 8 or 9 over the last 2.5, 3 months to do the automated pooling. You don't want people doing that. And then to make that new tube and to link it and run it through your laboratory information system, be able to track what is a new sample that we don't normally run in the clinical lab. So it actually creates a lot of upfront work, and it doesn't save anything on the pre-analytical part. So you still need all those people logging samples, but it does insure us against reagent running away from us if any of that happens. And that's really how we're planning to handle testing this winter. We've got each of those companies that have those large instruments have gotten emergency use authorizations in the last weeks with the FDA for pooling. So they were able to do that. Another illustration of why, as Keith showed, really important for our labs to be able to respond locally. We got our pooling authorization on June 29th, and Roche and Hologic got it, the first weeks of October, the last weeks of September. And so it's just the parts of those processes can just take time. And so now we're getting the informatics and the programming set up on those instruments to be able to handle that.
Thanks. Keith or Pavitra, any other thoughts about preparing for the flurry? All right. Moving on now, we have a question from Alan Boyle. Do you have adequate resources for testing, or are there still supplier pipeline problems? What are the next steps we're planning, and are we playing a role in contract tracing? I think I can tackle some of this. It has constantly been sort of scrabbling for purchase, trying to get a hold on the swabs in March, and instruments, and then reagents and people and everything. So I would say that we have adequate resources today. Tomorrow, you gotta ask me tomorrow how we're doing. It's always been touch and go. We are in we're in a crisis, honestly. And so this isn't like normal where we can open up a catalog or go to a website for the things that we need to run the lab, click on them, and then they show up in 3 days by FedEx. I've had to call in FedEx. I've had to use connections to get in touch with the C-suite of FedEx to have someone come and open up a trailer at SeaTac Airport on the weekend to take a box out of the back. It was like all the way at the back of the thing. And so it took an entire crew to undo a box just to bring us a box of tubes so that we could do the weekend's testing. And that happened just like a month or two ago, so it's still that level of acuity. But the major problem are what Alex alluded to is that, if everyone in the country just said, geez, UW can have whatever they want, we give it up, then we'd be fine. The problem is that there's more people wanting the stuff that we need to do testing than there are supplies. And so the larger groups get more attention, and quite frankly, supplies have been diverted by the vendors under the guise of under the direction of the federal government to divert supplies where they're needed, during huge spikes when Florida and Arizona had gigantic spikes, et cetera. So the next steps we're doing, I think we've alluded to all the next steps of that part for the pandemic. And then one of the things I'll kick it to after this too is one of the things that we're doing to respond to the pandemic is supporting vaccine trials. And I'd like to have Keith talk a little bit about that. But before he does that, I'll just mention contact tracing. We can only do so much in laboratory medicine, and we provide a lot of data. But contact tracing is in and of itself a very difficult thing to do. It takes a lot of talent and a lot of workforce. And so that is actually other individuals that are doing that. We're just providing them the data that they need of the positives or negatives for that. But Keith, did you want to talk a little bit about how we're supporting the vaccine response?
Sure. So one of the things that we've always tried to do is think about the next steps. So try to not be completely reactive, and even in a pandemic like this. So I had the privilege of being asked for input on laboratory testing about the vaccine trials and how that might work, and been involved in some of the calls for Operation Warp Speed and so forth. And we're actually lucky as an institution, the University of Washington is a provider of actual testing in support of some of those vaccine trials. We have a research group that's located actually up near Harborview Hospital that's doing that testing, led by Dr. Bob Coombs. And so for one of the vaccine trials, we're actually doing all the testing. So hundreds of thousands of tests for all the people who got the vaccine and all the people who didn't. And anytime anybody's got as much as a scratchy throat, they'll get a PCR test, and that'll come to us. For a couple of vaccine trials, we're providing more focused help. Here, one of the things that we set up very early on was not only the test to say, is the virus there? Yes, no, but to say how much is there? Do you have a lot of virus? Do you have a little? And we were one of the first labs to be able to do that. And as you can imagine, for a vaccine trial, one of the big questions is, well, if it didn't completely keep you from getting infected, did it maybe keep you from getting having as much virus? So maybe you're less likely to transmit, maybe you don't get as sick, all these things. That would still be a useful vaccine. So we offer the ability to do that. And so for some of the trials, we're doing that. And then finally, for several of the trials, our laboratory will do the sequencing of what we call the breakthrough infections. So if somebody's had the vaccine or the placebo, they do get infected, that virus will come to us, and Alex and Pavitra will look at that sequence and try to understand if there's unique things about that virus that shows either maybe how it escaped a vaccine or showed that it was more infectious and actually avoided all of our efforts to stop from it. So we're deeply involved. We're really excited. I would love the idea of being involved at the very beginning of this pandemic. It started here in the Pacific Northwest, and being right there at the end when we really beat it with the vaccine.
Yeah, that's really what I've been sort of dreaming of too, is sort of the light at the end of the tunnel of this sort of very, very, very challenging experience for us, is that we were lucky enough for a lot of reasons to be able to respond very early and help out. And I'm really hopeful that we'll be able to put the nail in the coffin on this one and say goodbye to COVID-19 also from Seattle. Next question, which is the last one here. Any other questions, please type them. Oh, no, there's two more here. The first one is a sort of a follow-up to something that I said. It said that it's important to reduce the demand for tests. How do we do that? Are there people who are getting tested but should not be? That's not what I meant, and I'm sorry if that was what I meant. I didn't meant that we want to refuse testing. What I meant is all of the social things that we do to prevent transmission, so distancing, masks, not having large congregate events, just maintaining our 6 feet. Those are the types of interventions. And masks specifically, we know those things work. We know that they help. And people wearing masks means that we don't have to do as much work here. We'd love to get out of the COVID testing business and back to what we were doing last year, but we're not going to do that until this really does die down. So the next question here is, what are our hopes that new diagnostics will be available during the pandemic? For example, some researchers have developed CRISPR-based tests. And so I would ask if Alex or Pavitra had any thoughts on CRISPR-based testing. Pavitra, maybe?
I think Keith is probably the best person to talk about this, as we did help with helping to validate some of those CRISPR-based tests. So
okay. We're just trying to spread it around. Then we haven't asked Alex or Keith Keith.
Yeah, thanks, Pavitra. Yeah, so we've been really interested in new sorts of testing modalities, and CRISPR is really exciting. In the non-COVID part of my life, I'm deeply involved in CRISPR as a therapy for viral infections. But we actually did a study that was published in New England Journal just about 2 weeks ago with Feng Zhang, who was actually one of the initial co-developers of CRISPR, and actually was talked about as winning the Nobel Prize. Unfortunately didn't. We were sad because we know him well. But actually, so we were able to collaborate with them on one of these CRISPR tests, help them take their technology, really optimize it for actual clinical testing, and then prove that it actually works quite well. Those are great ideas in terms of big, broad production and making the millions of copies of the tests that are actually needed. It's not there yet, unfortunately. So I hope that we get ahead of this and kind of get the vaccine before this thing lasts long enough that all these new technologies are actually there in a big way. But they're really easy now to adapt for the next pandemic. These ideas are there. It's really exciting. We've also done a lot of work in just simpler stuff, trying to actually take out all the extraneous stuff that goes into testing. You saw those big extraction instruments. In resource-limited parts of the world, they don't have those. We got robots do this stuff. They can't do it. And so we actually have developed versions of our tests where you don't actually need to do that. Now, they don't work quite as well as sort of these gold star tests that we do, but they work really quite well. And those have been adopted throughout the world in resource poor areas so that they can offer testing to their population with the resources they have. And we've been happy to really get to work with colleagues throughout the world on that and take what we've learned and share it to as many people as possible.
Thanks. I think there's a couple more here that are good, and they're sort of good. I think maybe even wrapping up ones, because they could go forever on this. But and I actually think this next one I'd like to ask, just so everyone on the call knows, I'm not a virologist by trade. I'm actually a toxicologist. My job is actually just paying for all of this as the department chair. But these three here are really international experts in virology, and I think that each of them will probably have a very good answer for this. So we'll just start with Alex, then Pavitra, then Keith on, are you learning anything that may help once this is over to deal with other existing infectious diseases such as flu, malaria, HIV, or whatever?
Yeah, definitely. I think this is a really important sort of hopeful point here to make, is that everything across the board can be used for other diseases. So for instance, the diagnostic platforms, we run HIV on and flu testing on these things. So a lot of these diagnostic platforms that are getting bought up and all the capital that's come, those can be used for more testing for other agents, provided there's going to be, people are interested in that and someone to pay for it. The vaccine trials are being run for coronavirus are being run out of the HIV vaccine trial network and the AIDS clinical trial group for some of the therapies. So we're using a lot of the HIV resources built up for HIV over the many last decades for the coronavirus. And then if you look at the vaccine trials themselves, I mean, it's multiple shots on goal with different platforms and different technologies. And I think also you're seeing a maturity in sort of an approach of looking at pre-fusion type 1 fusion protein. So every single developer is using a certain locked conformation of this glycoprotein, this outer viral protein that could work for many, many, many different viruses. And so if this approach works, we'll have to figure out the other adjuvants, the other platforms that go with it. But there's a lot of momentum that we could carry forward into other respiratory viruses that this would work. And so we're going to learn, we're really, one of the silver linings to all this, we're going to learn a lot. And we're going to be able to take that momentum and use it to really do things in other viruses as well.
Pavitra, thoughts about in your area applying to other diseases?
Yeah, as Alex brought up, and just following up there, a lot of the stuff that we're doing now in the sequencing space has actually come out of our previous work with herpes viruses, as well as RSV. And so I was just starting to analyze RSV sequences in January when this all started up. So we had this informatic pipeline that was ready to go. And the thing that we've done over the past few years and working with Alex is how to run these pipelines really quickly using high performance computing. So we had that set up and we could do that analysis part of it really quickly as well. So we can go from sample to sequence rapidly. And so that's really, that's something that we've learned and we can apply to other diseases also. And the thing that I think has really been amazing is this nationwide collaboration with other scientists through the CDC initiative and other places, social media and things like that. And so I have really enjoyed that. And I think that has been really valuable in sharing with other groups around the world. And I think that makes us more efficient in tackling these kinds of problems. And I think that will hopefully continue in the future.
And then Keith, any ideas about applications of what we're learning now to, I mean, you have extensive other work in other viruses, obviously.
Yeah, well, Jeff, as you and Alex and Pavitra know, I am an optimist at heart. And so one of the things that I really am excited about is taking this capacity that we've built in so many arenas of virology and applying it to all the other problems that we had before COVID came and applying to those after COVID's dealt with. And I really believe we're going to get at that point. If you look at, we had a very robust viral sequencing program before this started. In fact, for many weeks at the beginning, for probably 6 to 8 weeks, we were actually the biggest depositor of viral sequences into these public databases Pavitra talked about in the world. The University of Washington, bigger than countries. And since that time, we've actually built a bigger capacity. We can do logs more viral sequences that we can. We bought more instruments. They're much more capable. We can do so much more. And I'm really excited to start to apply that and the robotics that we have into the other things that I work on. You know, my research interest is in trying to find cures for viruses like HIV and hepatitis and herpes infections. And the capacity we've built now may pay such dividends for those efforts in the future once we get COVID behind us. So I'm really, really optimistic and excited for the future.
Great. I am too, and I just I would double down on everything they all said, because we've all thought about all of those things. Here, like the last question I see here is maybe a good one to maybe even wrap things up with, and I think we should also all maybe share a little vignette. It's what has the impact of the pandemic been on our personal lives? We'll go in reverse order. Why don't Keith, you start this one, and we'll go back towards Alex.
Sure. So yeah, this has been certainly the oddest 10 months of my life that I can ever remember. At the beginning, these were 100-hour weeks when this first got started. Right around the 1st of March, when just everything was really hitting the fan, and so yeah, it was a slog, and I'll be honest that you know, we had to deal with what was happening then, but as we got through March and into April and starting to get toward May, I just looked at this and quite frankly said, you know, I can't do this. I can't, you know, I have to actually find some kind of balance. And that didn't mean 40-hour work weeks by any means, but it doesn't mean 100-hour work weeks either. And, you know, I see in your question, did you go for a hike? And yeah, I've gone for a couple hikes, and I still hit some tennis balls. And, you know, we've got to do these things because we have to be sharp. And, you know, I'll tell you this much, I haven't had a day off since I can remember, but I have had some hours here and there, and that's really important. And I've encouraged our staff, every hundreds of people who work with us, they have to do that too, because we have to be on top of our game, because we have to do a good job with this.
Vitra?
Yeah, kind of what Keith said. So March and April were complete blur for, I think, all of us. And I think all of us hit different points of that, you know, I can't take this anymore, and a little bit of burnout. For me, I have a young child, so that is a bit of a blessing in the sense that I am forced to switch off for a little bit and, you know, deal with silly things like Peppa Pig and stuff like that for a couple of hours, and that's been almost therapeutic for me. And so I treasure those times. And so there the 1 or 2 hours that I get with my kid and my family, I make sure that I'm there 100%. And so that's been good, and they've been really understanding too, especially early on when I had to, you know, come in or stay up late or whatever and couldn't be there as much. But yeah, definitely found a few hours here and there, and taken a hike, or you know, I worked from home for the first time, I think, just a few weeks ago, and that was really relaxing for some reason. So yeah.
Alex?
Yeah, I mean, it's a really great question. It's just such a difficult, every month has been different. I'm just like in February and March, like being ready and being on top of it, and, you know, interacting with the FDA and helping to change policy on those levels, and to be ready to launch testing and make such a contribution. I mean, really there's, you know, we don't usually get to see the impact of what we do as often in the laboratory. It's sort of just, it's just there, it's assumed. And so to be able to create something that is instantly useful, and to have, you know, like doctors, you know, call and ask, like, you know, want to know where things are, like that, right those first few days. I mean, it was really just no other feeling. I mean, it's actually been hard to come off of that a little bit. And I think, as Keith said, basically, you know, March and Vitra said, you know, March and April were just such an adrenaline, and then May kind of, we hit this, actually slowed down in the lab, and we had fewer and fewer samples to run, and we're doing well, and you know, so the adrenaline goes away, and then in June basically was when we had its ramp up, when we did the nursing home mandate. And I think that was when you sort of, for the transition between the sort of, you know, very focused adrenaline, like all the time on, versus how are we going to make this turn into a marathon. The other thing I think is just that, in the lab, our volumes have never been higher. They just go up, right? We're now at 9,000 samples a day. We'll soon be at 10,000. Who knows what the next coming weeks will be. Even if there are fewer patients in Washington State, fewer people in the ICU and fewer people in the hospital, the lab has really not had a break. I mean, it's been 24 hours a day, 7 days a week, staffed all the time. So I think I'm more aggressively weekend is what I would say. I haven't really gotten a chance to take a total vacation or anything, but it's more aggressively weekending. I bought a car this last week. I went out and bought a bike. I feel like I'm going through what people went through maybe in late March or April, where we're looking at the market for things and realizing that a lot of things aren't there, but trying to do some self-care and trying to figure out how to handle this next wave. Jeff got his mile time probably down. What are you at, like 4:30?
Yeah. No, as I was saying, yeah, the beginning was a sort of a dark place for all of us. Literally here in Seattle, it's a little bit darker. And then that also, because just to put a quantitative number on this, March and April, for the periods where it was bad here, from about 6:30 in the morning till about 9 o'clock at night, I'd get about 1 or 2 emails a minute that needed to be responded to. And so I was just sitting in front of a computer on the phone or in conferences constantly, and it was incredibly stressful, and I thought I would go bananas. And then following trajectory too, yes, cooled down, has gotten hotter. And I was able to actually finally just cut it out, and I took a week off. Didn't go anywhere. I'm still not really comfortable traveling anywhere, getting on an airplane, but did take a week off and sat at home and just had to clean up some emails in the morning, clean them up in the afternoon, but spent a lot of time just not doing anything, and did get back into running, and so have been able to run most days now, and really budget some time to do that. So the self-care is really important, but it's been really very, very, very difficult. It's as bad as you'd think. And so we've all found ways to do this. And what's worse is, honestly, it's been the uncertainty for this. We've had a lot of other problems. The medical systems you're probably aware of have all suffered in the country because we had to stop doing elective procedures, and that's a major source of revenue. And so our whole medical system lost tens of millions of dollars doing that. And because of that, there were actually some employees who needed to be furloughed because we actually, needed to be financially responsible. And, when you tell your group, you guys are the greatest, you're helping this whole region survive, now go home without pay. That's a tough message to have, but we had to all do that. And we've all had to sort of take the brunt of that because that's what's necessary. That's the business we got into in providing medical care. So it's been really hard. And what we're worried about too is we don't know what's going to happen in November or December or January or February or March. None of us really know for sure. We have predictions and projections and all that, but there's been a lot of uncertainty. So it's been really tough to deal with. On that positive note, I see that we're, I think, out of questions here that are new. I'll kick it back to Susan for any other she's running the show here.
Well, thank you, everybody. I think it's a great discussion. If anybody has any questions they don't feel were answered, you could email me at sghansen@uw.edu. We also have our own newsroom, and you can see much of the work that this team has done on our newsroom, and that's newsroom.uw.edu. Appreciate everybody's time today and your participation as a panelist, and then the audience for asking such good questions and being a part of this. Thank you.
Thanks very much.